Hi there everybody, my name is Ollie, I'm a junior doctor living and working in the northeast of England. And welcome back to my YouTube channel. Now in my last video I talked about the 5 key lessons that I'd learned in my 4 months working in hepatobiliary and transplant surgery, my first job of FY1. But it turned out that you guys had a ton of questions about what life is like working as a junior doctor in surgery, so that's what this video is going to be about. I'm going to be short, snappy and try and get through as many as possible, and if your question isn't covered in the video, be sure to drop it down in the comments and I'll tackle it there. How do you go about convincing seniors to be involved in theatre other than just to watch? Really great question, and I think the key theme that kind of comes across in the question is just showing interest. Anyone who's not particularly interested in surgery usually won't want to get involved more than they have to, but for people who are interested, like you and me, it's really exciting and interesting to get stuck in, get scrubbed in, and be right in the middle of the action. And in my experience, I think the best way is just to express interest. Make it clear early on that if there's the opportunity to scrub in, get involved and assist, that is something that you would take advantage of. So build a little bit of a relationship with whoever your supervising surgeon is, consultants, registrars. Make it clear that you want to learn more, want to get more involved. 9 times out of 10 surgeons really enjoy having people involved in their theatres and in their surgeries, so just let them know and they'll help you. Michael Nixon asks, what was your working life like? What did the job entail and what about work-life balance? So let's just run through a typical day on the ward I worked in. Workday started at 7:45 AM. I usually left my flat just after 7 to get to work on time. That would give you a bit of time to begin preparing the notes for ward round, which is usually between 8:15 and kind of 8:30. That would usually take a couple of hours, so you'd be finished about 10:30, 11:15. That would generate all of the jobs that you needed to do for the day, whether that's bloods, cannulas, tests that need ordering, scans that need chasing, just a myriad list of jobs which could be different on each day. And then basically the rest of the day, that is until 5 o'clock officially, you would just spend actioning your jobs list. As time goes on, you'll pick up more of a sense of what are the jobs that need to be done first, so things like bloods and investigations, so that you can maybe get the results of those back before you go home and then act upon the results. And then at 2 o'clock we'd usually have another couple of doctors join for the on-call, so any jobs that we were struggling to get done by the end of the day, they could be given those jobs to do and make sure that we got our core important jobs done out the way and prepare the documentation for tomorrow when we can do the whole process again. Then the only things that change is that once a week you might have an MDT where all the senior members of the surgery team come together and talk through all the important and difficult cases. We had an hour of teaching once a week on a Thursday afternoon for all of the F1s. The only exceptions to the above rules being weekends, where you'd usually do a long day from 7:45 AM till 8:30 PM, or indeed night shifts, which are 8:15 PM through to 7:45 AM the following morning. There's a few questions here which are asking what are the hours like, what is the work-life balance like. Surgery was a really busy job, and being perfectly candid, a lot of my staying late, particularly at the beginning of the job, was simply an inability to prioritise properly. At the beginning of the job, you're a brand new doctor. My sense of what needed to be done now and what could be done later and what could be left till the following day or the evening, I had no inbuilt sense of all of these things, so I was staying an hour, 2 hours late almost every day for the first few weeks. And equally for the first few weeks, I barely was able to eat lunch because of task prioritisation. But as the weeks went by, I got slowly better at this, although I remain very much not perfect at this. I still had maybe a couple of nights each week where I was staying an hour or 2 late, but that was more due to things like patients suddenly deteriorating right before my shift was due to end. And often in those situations I find that it's easier just to clear up the mess as much as you can and try and hand over a completed treatment bundle to one of your colleagues rather than getting halfway through a problem without solving it. And on the note of having free time, in theory you should do, right? Because 7:45 AM until 5 PM still in theory leaves you the evening, so you get home at 6, manage to get something to eat, have a shower and all the rest of it. Most days, probably 90% of days, I was so tired by the end of the workday that I would usually just come home and fall straight to sleep. I wouldn't want to do anything, I wouldn't want to go anywhere. It was actually very rare that I had the energy to do anything in the evenings at all. Again, I think that was a symptom of it being my first job and not really knowing what I was doing, but that was the reality of surgery for me as my first F1 job. Emiragadi wants to know, is it better to start FY in surgery or medicine? I can't tell you, is obviously the honest answer, because I've only done one job so far and I started in surgery. Do I think that surgery, especially working in HPV and transplant, has prepared me well for my next set of jobs in medicine or surgery, whenever that may be? Yeah, I actually do, because there's a mix of the hands-on stuff that you need to do, bloods, cannulas, catheters, all of the routine, important things that a foundation doctor needs to be able to do, as well as managing acutely unwell patients. In my first job, I saw sepsis, cardiac arrests, hyperkalemia, acute upper GI bleeds, and had to manage lots of quite complex, multi-morbid patients, because pancreatitis patients usually have everything going on all at once. So I can't say obviously that surgery is better than medicine, but I do think that surgery is a good springboard, and I certainly don't feel like I've missed out on any amount of significant experience. Can you make a day of my life video as a junior doctor, please? The simple answer is going to be unfortunately no, and there is a reason why I tend to steer away from this type of content. Again, I know I made a night shift one. The reason why I did that is that nobody is actually around at night and relatively little happens, as odd as it sounds. It should go without saying that especially during the day, people should not be filming in hospitals. Most hospitals, in fact every single one that I've trained and worked in, has a no filming policy, truth be told. There's obviously a reason for this, it's to protect patients. It's to protect patients and their information that may be in the environment, as well as your colleagues who probably won't want anything to do with the things you're filming. But the other element to it is, I think that since we're filming inside a sensitive environment, right, it should be done for a purpose, to demonstrate something. And as a medical student and now as a junior doctor, I am actively not convinced that we're adding value to anything by filming the things we're doing. Certainly the benefits wouldn't outweigh the risks of accidentally capturing something, and I know I've been lax on that sometimes in the past, but it's something that I do actually feel quite strongly about and I think is usually inappropriate. Is it more competitive than other specialties? Getting surgical jobs as a junior doctor, as a foundation year 1 and 2, isn't almost by definition more competitive than anything else, because all foundation job lists, that is your combination of the 6 jobs you do in the 2 years, should include a mix of medicine, surgery, and community specialties like GP and psychiatry. So virtually all junior doctors will do at least 1, if not 2, surgical jobs. Now if there is a specific, more niche or subspecialist rotation that you want to do, something like ophthalmology, neurosurgery, transplant surgery, cardiothoracics, plastics, then these are going to be more highly contested. And so I'm sure that neurosurgery F2 jobs are very competitive at the application stage. General surgery jobs will absolutely not be, but I wouldn't worry about it too much for foundation training. Dizzy Lazy Eve wants to know, have you made a decision on an emergency case without the help of a senior? I think the simple answer is that it depends on exactly what you mean, because obviously even as medical students and PA students, we are all trained in what to do in an emergency if you're the first one on the scene. By the end of your training, you'll know how to deal with an anaphylaxis, a GI bleed, a cardiac arrest, hopefully. At the very least, you'll know what to do in the first instance, even if that is as much as calling for help and giving some adrenaline. So in the sense that, have I been the first one at the scene of a medical emergency and started initiating treatment without calling a senior? Yeah, of course, but that's a fairly routine thing to do. I certainly don't think that at my stage it would be appropriate to sort of witness an emergency, try and do all the management myself and then not tell a senior about it. I think that would be grossly irresponsible. Usually in practice, you'll be the first one on the scene, you'll start doing your initial management, call for help, and then make sure that a senior comes and reviews and gets involved in case it goes south. So an example case might be sepsis, right? Sepsis happens a lot in surgical patients. You'll see it probably on your first day on the wards if you work in surgery. Now, even at the point of suspecting sepsis, usually that is enough to go ahead with the treatment bundle. The sepsis 6, 3 in, 3 out, fluids, oxygen, antibiotics in, blood cultures, lactate, and a urine output out. Now, would I be comfortable doing all of those 6 things before calling my registrar? Yes, at this point I absolutely would. I would do all of those things, then call my registrar, say, I've got this patient. On the balance of probabilities, I decided to treat them as a sepsis because of XYZ. I have done the sepsis 6. Could you please come and review? Is there anything you would like me to do before you get here? And I think quite quickly you get used to that process. From Psych to Med wants to know, how many hours do you actually work on average per week? So in an average week, let's say I was doing 7:45 till 5, let's call it 8 till 5, 9 hours. Every day, Monday to Friday, that would be 45 hours. However, I would also work 1 in 4 weekends, I think it was, in which case it is perfectly possible that you could do Monday to Friday 45 hours, and then 2 12-hour days on the weekend, Saturday and Sunday. And that wouldn't be factoring in staying an hour or 2 late on any of the other days, if not on your weekends as well. I would say for me, maybe in the low range, 44 to 50 hours a week, something like that. I think in my busiest week I worked something like 80, 82 hours, I can't exactly remember. Baha29 says, do you have any regrets about your medical journey, being 100% honest? Regrets? No. I genuinely don't. Depending on exactly what you want, it can be an objectively very, very poor career choice for a very large number of people. However, I do think for some percentage of people that it is the right career. I feel like for me, it is the right career, and I absolutely don't regret going into it. Taran wants to know, is it difficult to get involved in audits and research in general surgical rotations? I wouldn't have said that it was hard at all, especially if you've got some research experience in your pocket already that you maybe could do as a medical student, because especially in academic units like the hospital, because especially in academic specialties and in academic hospitals, like where I've been working, they're just generating so much data all the time that there will always be audits and research and things that need doing. However, I would say the difficulty in practice is certainly for myself, I was too tired. I had no energy at all to do basically anything outside of the job, let alone think about coming home and doing research and audits and things. And that's actually so far what I'm finding to be the value of now moving on to an academic job where I have the protected time. You wouldn't struggle to get research and audits in most surgical units. I think the question is more, are you going to have the capacity and the energy to actually do them, especially on a very busy job? What you might do is either leave these projects like I'm doing for your academic rotations if you have an academic job, or you leave them till a quieter rotation and you come back to the same unit and do your project then. These things shouldn't be half-assed, they need to be done properly. You need to make sure that you've got the capacity and the energy to commit to them and make sure you see them all the way through and get your outputs. Dr. the Doctor wants to know, how much time do you actually get in surgery and how involved are you? I'm sure this massively varies depending on the unit that you're in. Unfortunately, in my job, I got very little time in theatre, certainly not as much as I would have liked. And obviously being in theatre is an additional opportunity that is not really your job, it's a thing that you can do if the ward isn't busy, but 99% of the time the ward is busy and you need to be on the ward, dealing with ward patients and doing ward jobs. And that's absolutely not meant to be a negative reflection of the unit that I was working in. They were always actually really keen for juniors to come to theatre and were always asking for assistance and stuff. When they needed another pair of hands up, the registrars were great for that. The second part of the question, how involved are you? You can be as involved as the operating surgeon lets you be. And that might be a spectrum from being stood at the side watching, and sometimes that's as much as you can do if you quickly need to go back to the ward but you just want to see how a bit of an operation is done. So in the cases that I was able to be involved in, you might pilot the laparoscopic camera, so you're controlling the camera while the surgeon does all the operating. You might do some of the sutures when you're closing up. It basically just depends what the consultant or the registrar is happy to let you do and how much they trust you, how much rapport you have and how skilled you are. When the surgeons were operating and you needed help or advice, what did you do? Now this is actually really hard, right? Because in medical school, in an emergency, especially preparing for the SJT and things, you're always taught sort of go up the chain O command. If you don't know what to do, call your registrar, call the consultant. In this job, I often found that the registrar, the consultant were busy. In theatre, they couldn't answer the phone even when there were acutely unwell patients on the ward. Like, this guy's septic or this guy's going off spewing blood everywhere, I don't know what to do. And your normal chain O command is broken and doesn't work. What I did in those settings, and I think what I can advise you do, is sort of get the next most sensible person, which in practice for me was just a different registrar or a different consultant that I thought would probably know how to solve the problem immediately. And I actually never had anyone put the phone down on me or snap at me in that scenario. Just a sort of, hi, I'm really sorry, this is what's going on, I can't get hold of my reg or consultant, they're in theatre, can you please come and help or give me some advice? They always reacted positively to that, and I think it was the right thing to do. Chloe9033 wants to know, what's the ratio of female surgeons like? Unfortunately, in my particular unit, there were no female surgeons in HPB and transplant, and I think this is an okay thing to talk about because it's just an observation of reality. There were 3 different teams that I worked as part of, so normally I was in HPB and transplant, but I also covered vascular and colorectal surgery at other times. Colorectal had 1 female consultant, and I think vascular was about half and half. I feel like there were 2 male and 2 female consultants. But we know that women are underrepresented in virtually all surgical specialties, and there's a lot of research going on into this. On the flip side, we do have to remember that we're dealing with very, very small sample sizes here, and a lot of weird selection pressures. This was an academic hospital in a very niche subspecialty, with lots of senior clinical fellow posts and not training posts. All of that statistical stuff aside, there were not many females in this surgical department, as you would perhaps expect in most surgical departments. Are most surgeons horrible? Asked John Smiley. No, hand on heart, actually virtually every surgeon that I worked with during this placement has actually been really nice, especially if I approached them with something that I wasn't sure about, or I was dealing with one of their patients and I wasn't sure exactly what they wanted me to do, just due to inexperience and the quite complicated nature of a lot of the patients we had. They were very understanding, like, yeah, obviously I wouldn't expect you to know this detailed bit of subspecialist management. In very simple terms, this is what I would like you to do. If you have any more questions, just call me back. So that's it, guys. I hope that has answered some of your questions. If you've got more, just let me know down in the comments. Please be sure to go and check out my website, ollieburton.com, for more videos just like this, especially if you're preparing for finals, and be sure to subscribe to the channel, leave a comment, and I will see you next time. Bye bye for now.